I'm Dr. Christy Sutton, and today we are going to be talking about understanding the role of iron overload and undiagnosed anemias in chronic patients who cannot recover. Disclaimer, this is for educational purposes only and is not intended to diagnose, treat, or prevent diseases. And I just want to start out with why this topic is so important to me. I married a man who had undiagnosed hereditary hemochromatosis, which was causing him a lot of liver damage and potentially also caused him to grow a pituitary tumor, which I'll go into more detail about later. And going through the process of writing my first book, The Genetic Testing, Defining Your Path to a Personalized Health Plan, I realized that my husband had a hemochromatosis gene. And I realized, this is why I keep telling him he needs to donate blood whenever he brings home his labs from his primary care doctor, although his primary care doctor wasn't really saying anything about having high iron or needing to donate blood or even his liver enzymes being high. But once I realized, he has a hemochromatosis gene, I realized, this is why this problem's happening, and we really need to do something about this. And eventually, we got him properly diagnosed through a hematologist. But before that, we went through this kind of diagnostic rabbit hole where he got misdiagnosed with autoimmune hepatitis, and they even thought he might have polycythemia vera. And then eventually we got the diagnosis and his liver's better. We did find out later that he had a pituitary tumor that was causing him to have Cushing's disease, which the anterior pituitary gland, I'll talk more about this later, but the anterior pituitary gland is very sensitive to iron damage. And so a lot of times people that have too much iron will develop problems with their anterior pituitary gland. And my husband grew a ACTH producing tumor, which caused him to develop Cushing's disease. And that was a whole nother process that we had to figure out and go through. So while he's dealt with a lot of high iron issues that are now under control, I have personally had the other extreme where I have dealt with a lot of low iron issues, not just because I'm a female and menstruating and pregnancy and all that is a factor, but the primary reason that I have dealt with low iron issues is because when I was 16, I had the last foot of my small intestine removed because I was diagnosed with Crohn's disease. And because of that, I have had to be on a bile sequestrant long term. Otherwise, the bile will go from my small intestine to my large intestine and act as a laxative, and then I get bile diarrhea, which nobody wants to have. So I have to be on this bile sequestrant to prevent side effects of not having that part of my small intestine. But one of the problems with being on a bile sequestrant is that it makes it really hard to absorb a lot of nutrients, including not just fat-soluble vitamins, but iron especially, and some other minerals. And so I have dealt with this kind of chronic challenge with getting enough minerals and vitamins, and iron is one of those. But the real reason that I lost a foot of my small intestine is because I was not properly diagnosed with having celiac disease. So I do have a celiac gene, and just about every Crohn's patient that I've ever seen, with the exception of maybe one, has had a celiac gene. And I believe that really I had undiagnosed celiac disease, and I was being treated with a lot of antibiotics because I was having digestive issues from the celiac disease. And then the antibiotics just ruined my gut microbiome, and it created this autoimmune situation where I then developed Crohn's disease, and at 16 lost that foot of my small intestine, and now I'm dealing with the side effects of that. So I think just within my small family, my husband and I are an interesting example of both sides of the coin and both extremes, and how this story of iron is complex and important and often overlooked and misunderstood and topic. And there's a lot of myths that I hope to dissuade and dispel and help people really understand this topic, that if you do understand it, you can help so many people, because what we're talking about are very easy labs. Iron panel, CBC, these are very easy labs that a lot of people are not running. And we just have to make sure we really understand what we're looking at and ordering the right labs. So that's my why. And then, of course, I have my daughter who I want to make sure that she doesn't develop celiac disease, even though I gave her my celiac gene. And she doesn't develop hemochromatosis, even though my husband gave her hemochromatosis gene. And I want to create generational health for my family. And I want to help the world have more generational health. And that's where my approach is with this topic today. And I want for this topic to be really clinically relevant for clinicians so that they can go out and make an impactful, meaningful change in their practice and help more patients. And ultimately, I think what the underlying current of this whole topic today is going to be we have to make sure we're getting the right diagnosis. And I'm going to talk heavily about hemochromatosis and iron overload because it's such a common but undiagnosed health problem. And let's dive in. It's easy to miss seeing something if you don't know what it looks like and you're not looking for it. So this is hereditary hemochromatosis and anemia. These are both easy to diagnose, prevent, treat in many cases, yet many people are undiagnosed and untreated. So hemochromatosis, iron overload, I'm going to use those words interchangeably. They both are conditions where you have too much iron, and they are disorders of having too much iron, and these are easy to screen for, easy to diagnose, easy to prevent and treat, yet most people go undiagnosed and untreated. Whereas anemia is a disorder of not having enough healthy red blood cells or hemoglobin, and again, easy to screen for, diagnose, prevent, and treat, yet many people go undiagnosed and untreated. And really, the theme here is we need to get to the root cause of why are these happening? Don't just diagnose them properly, but why are they happening? And then you can really help somebody on a much deeper level. A lot of people think anemia is just iron deficient anemia, and that is one type of anemia that we are going to talk about. But anemia really simply means you just don't have enough healthy red blood cells and hemoglobin. And you can be both anemic and have too much iron. So that's called iron loading anemia. And we will talk more about that. But I just wanted to kind of plant that seed that you can have too much iron and be anemic at the same time. So if we want to really understand iron, we need to understand the braking mechanism that our body has for controlling iron absorption and controlling iron largely in the body. And that braking mechanism is largely hepcidin. So hepcidin is a hormone that is produced largely by the liver, and that hepcidin will bind to the ferroportin protein, and it will break down that ferroportin protein, which then stops iron from being absorbed through the intestinal lining and getting into the blood. So if you look at this image on the left, then you'll see that there's way more hepcidin. So hepcidin is like this little green moon-shaped thing coming out of the liver. And then the ferroportin protein are the little blue bars. And then in the enterocytes in the intestinal lining, the little dots in the cells are the iron. And so the iron has to go through the ferroportin proteins to jump onto this transferrin to go travel through the blood and go to the rest of the body. And if you naturally have too much iron because like you're just eating too much iron-rich foods, or you're on a carnivore diet or whatever, then your body will put the brakes on iron absorption, and those brakes are hepcidin. Okay. The problem is that people who have hereditary hemochromatosis, they don't make as much hepcidin, and so they don't have that braking mechanism, and they just keep absorbing iron, and there's no braking mechanism, and they absorb more and more iron, and that creates a lot of problems. So if you look at this image on the right, then this is a liver that's making less hepcidin, and the less hepcidin is going to increase iron absorption. So you'll see this image on the right. There's less iron trapped in the enterocytes and more ferroportin proteins, allowing that iron to jump onto the transferrin and go through the blood. typically, if somebody has a healthy person or a normal person without a hemochromatosis gene, if they have low iron, then their liver is going to be making less hepcidin to help to increase iron absorption and not break down those ferroportin proteins. But like I said, people with the hemochromatosis gene, they make less hepcidin, so they're naturally going to absorb more iron. The image on the left can also be what happens with anemia of inflammation. When people are inflamed, hepcidin is produced. It's anti-inflammatory. And one of the reasons that the liver and the body makes more hepcidin whenever you're inflamed is because the body knows and the immune system knows, like, when there's an infection, then iron is going to feed that infection. And so the immune system will basically tell the liver to make more hepcidin so that you can stop putting fertilizer on the infections in the body and the blood, especially in the blood. And then that hepcidin will decrease iron absorption, so you won't have as much iron coming in through your gut lining. But also, if we look at the next slide, then the hepcidin, it doesn't just affect the intestinal lining, it will also affect the liver and the macrophages. So the liver is largely where we store a lot of iron. And when you're inflamed or if you have anemia of inflammation, you're going to be producing a lot of hepcidin. And then the ferroportin proteins on the liver are going to get broken down. And you're then going to have more iron being stored in the liver as ferritin. You're also going to have more iron being sequestered in the macrophages. So the macrophages are important sponges for the iron to go into whenever the body is trying to get it out of the blood. And so the iron will go into the liver, stay in there, go into the macrophages, stay in there, and stop being absorbed from the digestive lining. And the end result is that you'll have, from having high hepcidin for a transient period of time, hopefully, you will have a decrease in iron absorption and sequestering of iron in your gut lining, your liver, and your macrophages. And this can create problems. This can create inflammation in the gut lining. This can create inflammation in the liver. This can create inflammation in the macrophages, especially if that goes on for a long period of time. But hopefully the inflammation is short term and the hepcidin goes back to a normal level, and then you have less sequestering of iron in the intestinal lining, the liver, and the macrophages. So if you look at the image on the right, this is where you have less hepcidin, and then you're going to have more of those ferroportin proteins, transport proteins, and then the iron is going to be absorbed more, and then the body is going to use that iron, and there will be some iron in the macrophages and the liver. With a person that doesn't have too much iron overload, hemochromatosis, it's not as big of a problem as far as lower levels of hepcidin because the body can control, okay, we need to put the brakes on. But what happens with people that have hemochromatosis is their macrophages, their liver, their intestinal lining, and every other cell basically in the body just becomes overwhelmed with iron, and it's like a hoarder that just, there's way too much iron, and it doesn't really have good places to put it in the places that are designed for it, and then it just starts putting the iron everywhere.